Okay, welcome back. So prior in the first video, we were talking about mental health conditions, talking about some different neurotransmitters, things like that. So now let's talk about the different neurological disorders. And again, this is not an end all be all list. There are plenty others that are not on this set of slides, but we're gonna do what we can. Okay, and this will work. Okay, so multiple sclerosis, also called MS. I've mentioned it a couple times this semester so far with this unit because remember we talked about the neuron and the different parts of the neuron, specifically the myelin sheath. Okay, so remember that myelin sheath is there to help propagate and speed up that action signal as it goes down the axon from the soma or the cell body up here. You want consistent, speed and, things like that, just like you want consistent internet speed, right? Same thing with your nerves. You want consistent action potentials happening so that your signals get from point A to point B on a consistent, timely basis, and you can respond accordingly to whatever you need to respond to. So, most of the time that works well and good. Wonderful. Then we have something called multiple sclerosis, aka MS. So, this is a chronic, meaning lifelong, long lasting disease, specifically in the central nervous system. And it's also specifically an autoimmune disease. Okay, so your immune system is there to defend your body from things that shouldn't be there, pathogens like bacteria, virus, etc. Autoimmune conditions like MS or arthritis or things like that, they can be considered autoimmune because remember, auto means self. So it's essentially the immune system attacking the body. The immune system signals get kind of wonky and it doesn't no longer recognizes the cells of the body as being there, so like they're supposed to be there. So it attacks itself. That's not good. In this case, when this happens, the myelin sheath breaks down, which is then going to cause delays or interruptions in the communication between the different neurons, between the brain and the body, etc. There are different kinds of MS out there, and it's based on symptoms and as well as the frequency of their relapse. So how often these symptoms get really, really bad, basically. In between these periods of like really, really bad symptoms, there can be some brief remission periods. It again varies person to person based on their age, their health, etc. Sadly, there is no cure for this condition. There are treatments out there that kind of help mitigate these symptoms, but there's no cure. They are trying to find a cure. That'd be really great. Like I know several people personally that have this. One of my best friends actually has it. And how I found out she had it is we were in college and we traveled to Minneapolis together. And, we're sharing a hotel room because it's cheaper. And I look over one night as we're, just watching TV and she's got this giant, like, tube looking thing that she's about to, like, poke into her stomach. And I'm like, what in God's name is that? What? And she's like, oh, it's shot day. I was like, huh? I was like, explain yourself, madam. So basically, it's an auto injector because it needs such a high dose of medication. She has like this auto, kind of like how EpiPens work, but scarier. And apparently it hurts, she said. And so she had to inject herself, I think, every couple weeks. I can't remember what it was. But I was like, oh, that looks horrible. And that's just one of the things she does to mitigate her symptoms. When she goes through these relapses, so you remember you got your ventricles in the brain, they store cerebral spinal fluid. Sometimes around those ventricles and things like that, there can be lesions in the brain and on the spinal cord with MS, which can it causes pressure to be different and painful, and it can push up on areas that shouldn't have extra pressure on them and things like that. So like she'll start like having some of these other symptoms down here, like she has slurred speech. She doesn't make a lot of sense when we talk on the phone. She gets very tired. Her coordination goes. She's constantly falling. So that's when if I see or hear these symptoms, I'm like, get B to a doctor now, go, because something's going on. She needs to have her brain checked. So for treatments, again, they have those injections. So you can get IV infusions of certain medications. There's different medications that they can take for like pain or to relax the muscles. They can take steroids to help with some of the inflammation. There's different therapies like physical and occupational therapy that can help. Sometimes in some folks, their lifestyle or diet changing can help. Again, it varies person to person, and the disease is neurodegenerative, so it does get worse as time goes on, unfortunately. So later on, they may need things like an assisted device, like a scooter or a cane, or something like that that helps them get around more comfortably. Okay, then we have dementia. Okay, so dementia is the very broad umbrella term for a decline in cognitive skills. So when I say that, I mean memory, communication, behavior, your personality, all of those things we've been talking about. And this decline then causes interference with your daily life. Okay, so there are different kinds of dementia. You can see from this little infographic I found from the Alzheimer's organization. So Alzheimer's is the one that gets the most notoriety, the most, it's most well known. And a lot of people mistakenly use the term Alzheimer's in place of dementia. Okay, so Alzheimer's is a type of dementia. Dementia is the broad category, Alzheimer's is a type. All right. Either way, if we're talking about dementia itself or Alzheimer's in it more in a minute, dementia is not a normal part of aging. Okay. Some memory slips every now and then as you get older. It happens. Okay. Again, your brain is getting rid of things. It's like, we don't need that anymore. Okay. It happens. But healthy aging does not involve dementia. Okay. And which type of dementia you have is going to be based on when did it start, what caused it to start, so like environment, genetics, etc., or the severity of the symptoms. How much are they actually impacting your life? And even within these different types of dementia, there are stages to each one. So specifically, let's talk about Alzheimer's, because again, it's the most well known. Yes, it is always with a capital A because it was a person's name, the person who discovered it. I've talked a little bit about Alzheimer's this semester because, as well as a little bit about dementia, just because of my own personal experience with it. So remember, I used to work in a lab where I studied the aging brain, specifically Alzheimer's and things like that, because Alzheimer's does get a lot of attention because it is such a well-known name, and that's fine. But also from the other personal side is my family. My grandmother had some form of dementia. Now, when I say had some form, I don't tell you what kind, you're probably going, well, and? Well, we don't know for sure if it was Alzheimer's or not, because you cannot diagnose Alzheimer's with 100% accuracy, or really even firmly affix that title of Alzheimer's as a diagnosis until the person is deceased. Okay, so what happens is if the family or whoever wants to know for sure was it Alzheimer's, what they will do is they will take some of the brain tissue and after death, post-mortem means after death, and we'll look at it under a microscope. And then I'll show in the next slide some things that they'll look for. Okay, obviously you can't really do this with persons alive. However, in the modern age of technology, wonderful that it is, there are tests to kind of pick up on the very probable causes, if you will. So there are machines called fMRIs, functional magnetic resonance imaging. So that's where it can take like lots and lots of images of your brain in real time and shows like what areas are active and things like that. So we can look at activity levels in the brain. Like when you're in the fMRI machine, they can ask you questions and they can see what areas of the brain are, lighting up, things like that. And we can also look at the brain itself in terms of the physical structure and how much is there. Because if you look at this picture, it's a very jarring picture. A healthy brain looks like this. You'll notice an Alzheimer's brain is considerably smaller. The grooves here are much more pronounced. Okay. It doesn't look good, right? And this is what happens with Alzheimer's and a lot of dementias is the brain physically shrinks because when you're losing neurons and therefore the connections between them and other neurons are broken, we're losing physical matter of the brain. And over time, that just compiles, it snowballs. And this is why we have so many different symptoms with Alzheimer's, such as obviously memory struggles, memory loss. Sometimes it's a simple thing as, oh, I forgot what the name of, a water bottle is. Or sometimes it can be we talked about Broca's area and Wernicke's area. It can be a situation where it's like I'm holding a spatula out, and it's called a spatula, but you can't tell me what a spatula does or where it goes. It's different. So there's different ways it can show up. Sometimes, especially in the earlier part of a dementia case, they may catch themselves. The patient may catch themselves. They call you the wrong name. They go, "Oh, no, you're not Lindsay. You're Jessica," right? They know that. But later on, they don't catch themselves because they don't realize it's wrong because we've lost more brain tissue. They can get lost in familiar places. We're talking like small town Oklahoma where they've been 100 billion years. Like they know the place and they get lost. Okay. They may repeat questions. They're one of the most jarring changes that was hard for me to see with my grandmother was her personality changed because of the structural changes happening in the brain. Literally, people can get very irritable, very angry. They can become they can develop different interests. It can be a complete personality switch, and it's very hard for families to see that because the person with the condition doesn't realize what's going on. They don't realize they're being irritable and grumpy at their family. They're just mad at whatever it is. And your family is like, but that's not grandma, that's not auntie, that's so it can be really hard. And one of the things that makes Alzheimer's different from other types of dementia and why we look at the tissue under a microscope and post-mortem is because it is characterized by these certain proteins, which are called amyloid plaques, and there's another one called a neurofibrillary tangle. I can't talk today. And those proteins are visible. So basically, these proteins start blocking the signals that neurons are sending to each other. And eventually, when that neuron stops getting enough signals, it goes, okay, no, you're kind of like, no, nobody wants to talk to me. And it'll eventually die off, which causes the brain to shrink. And it's like, again, it's a snowball effect. And so you can see these plaques, especially, and these tangles in the postmortem brain. Okay, so you can see with like a PET scan. You can also do it, like I said, fMRIs. You can see the different brain activities. Okay, notice how this one is more kind of spread out, like more areas are affected. Then over here, I got some areas that are really, really cool, if you will. So the cooler colors like blue and stuff, that means less activity. The closer it is to red, that means more activity. Okay, and then here's kind of showing like a cartoon. So healthy cells, these are all the little neurons. Remember all the dendrites branching out, talking to other neurons. Here's little somas, axons, all that stuff. This is what it's supposed to look like. Nice, healthy, nothing in the way. Well, this is where the kind of plaques and tangles and stuff get in. See how it is kind of blocking their connection? It's interfering in that synaptic space. It's not letting neurotransmitters through. It's not letting signals through. And you can start to see this neuron is struggling. It's very, very close to death, if not already there. Okay, so you can see different, you'll see shrinkage of the hippocampus. That's your memory. That's why they have memory issues. The ventricles get bigger. Okay, the cerebral cortex is going to shrink. All of this is just compounding, and that's why Alzheimer's can be such a devastating disease. When it comes to Alzheimer's, that you don't die because you forget your kids' names. Eventually, all these neurons and stuff that are dying off, they start going into areas that relate to, like your autonomic nervous system and things that you don't control, like swallowing. Yes, I can consciously swallow, but we don't think about swallowing, right? It just is a normal reflex. Once these neurons that are being destroyed are branching off into other parts of the body controls that we need to function, that's usually what gets them. A lot of Alzheimer's patients actually choke to death. It's horrible. It's horrifying. It's horrifying. I can't even say the words. Oh my God. So, okay. Parkinson's is next up. Again, this is neurodegenerative. Neuro meaning nervous system. Degenerative meaning it gets worse over time. Okay, just like a lot of the others we talked about, MS, Alzheimer's, they get worse over time, right? And this is a movement disorder. Okay, so again, we have a loss of neurons, specifically the neurons that produce dopamine and norepinephrine. Dopamine is a big player in Parkinson's, big player. Okay, when these neurons are lost. We're not exactly sure what is going on. They're still doing research on it. We have found some environmental exposures. We found some genetic exposure, onset, things like that. Um, Interestingly enough, for Parkinson's, men are more likely to get it. Similar to the brain of an Alzheimer's patient with the tangles and the plaques, if you look at the brain of a Parkinson's patient, they have Lewy bodies. It's another type of protein that's also, again, interfering with signals and causing problems. So symptoms. Oh Lord, how do you go to sleep? Symptoms include tremors, slower movement, which is called bradykinesia. Brady meaning slow. Okay, you'll see that again when we talk about the heart next unit. Brady and tachy, fast and slow. Okay, they can have rigid muscles. Their posture gets all out of whack, as well as their balance. They have changes in speech. There can be some cognition concerns as well, a little bit of memory loss, thinking troubles, things like that. So, while there's no cure for Parkinson's, there is a really, really good medication out there. So they have essentially made a synthetic or a man-made version of dopamine, and it is called levodopa. Levodopa, okay? And it is literally a medication they take. It mimics the effects of dopamine because it's basically a very, very similar molecular structure to dopamine, and the body accepts it as dopamine, and therefore it's wild. I can't show you in this video, but I can show you in class. When they give these patients levodopa, they're sitting there, shaking, trembling, like they have trouble controlling their movements. Like they'll sit there and shake like this, or they just can't control their movements. You give them levodopa, within an hour or two, even less in some cases, and they are just back to normal. It's mind-boggling. Okay, so I feel like we could be really close to a cure. For now, it's more management, because like if you do miss a dose of this synthetic dopamine, you go back to where you were. So it's not a you're good for the rest of your life. It's a you're good for now, but we're getting there. Okay, Huntington's. So Huntington's is, again, a neurodegenerative, meaning it gets worse over time. And again, we're causing a loss of brain cells. So brain is shrinking essentially, which is going to lead to loss of motor function. Again, they cannot control their movements, and a loss of cognition and things like that. This one is rare, but we can actually track it because it is a genetic mutation. So specifically, it is an autosomal dominant. So if you remember from genetic unit in biology 1, remember you got your chromosomes, little X guys over here. Okay, your autosomes are all your main chromosomes, and you have your sex chromosomes at the end. So specifically, they have found on chromosome 4, there's a mutated gene, HTTT. Okay, when a person inherits just one copy, because it's autosomal dominant, just all you need is one parent to have this. There's a 50-50 chance you'll have it. If you get that copy, you have it. So say mom has it, dad doesn't. So nowadays they can do genetic tests before parents have kids to find out if they're going to pass on genetic concerns like Huntington's. But sometimes people don't know or don't want to find out till later in life. So the reason Huntington's is still around, frankly, is because the symptoms don't start until your 30s or your 40s. Well, if you're in your 30s or your 40s, for most people, you are past and done having kids. If you're going to have kids, you've already had them. So that means if you have the autosomal dominant mutation and you have kids, by the time they're old enough to be around and know what's going on, you're going to start to show symptoms, which then leaves the kid in kind of a hard spot because they've asked themselves, do I want to get genetic testing to find out if I'm going to show symptoms one day? And that's a really hard place to be in. And again, there are medicines that can manage the cognitive decline. There are some behavioral changes that can come about, and we can kind of manage some of the physical sides, but there's no cure again. So it's not something I would wish on anybody, but again, it's a hard place to be. If you know that condition runs in your family, I can't tell you if you should get tested or not. That's not my choice, but But I will tell you, it is probably really hard to watch a family member have this because it is pretty debilitating. And they've got trouble again with walking and other movements. There's a lot of involuntary movement going on. Like they cannot, it looks like they can't sit still almost. They also, again, have trouble swallowing, speaking. They can't process information. You know, a lot of the same symptoms we've been seeing over and over again. So, okay. These two, stroke and aneurysm, kind of tie into the next unit we're going to do, which is the cardiovascular system. But because they do both involve the brain as well as the blood vessels, I was like, you know what, we're going to do it in this one too. So you will hear me mention stroke and aneurysm in the next unit. Don't be shocked. Okay, so first and foremost, stroke and aneurysm are basically the exact opposite of each other. One is a clot, one is a bleed. Okay, so that means there's two different patterns and things you need to do for treatment. Okay, so let's look at stroke first. Stroke is a clot. It is a blockage. So in your blood vessels, you've got a ton of blood vessels all over your brain and in your neck and face and everything. And you go into your heart, obviously. If there is a blockage, that means blood, which is carrying oxygen, kind of important, cannot get through. Which means if this is happening in the brain, specifically, stroke usually refers to a blockage in the brain, but you can also have clots in like your legs, and you can have pulmonary clots and things like that. They're different things, but very similar. When that oxygen and stuff cannot get through on the blood, now the cells start to die, or they get damaged at the very least. Remember how we talked about neurons and other nervous system cells? They need oxygen like all the time, like that, like now, okay? And they don't have a high tolerance for lack of oxygen. So this is why stroke can be life-threatening. The lack of oxygen in the blood getting to an area of the brain, especially if it's like something possibly related, like, I don't know, the autonomic nervous system, things that control your heart rate and things like that. This is not good. You need hospital now, okay? So, symptoms, headache, sudden vision problems, numbness or paralysis in the face or limbs, especially if it's one-sided. Okay, that's a dead giveaway. So, they may have trouble speaking, they may suddenly have trouble understanding language. Like, this is an acute condition, like it's a sudden onset. So the acronym FAST, let me show you right here. So this is from the American Heart Association. This is an acronym like frankly everybody should know. Okay, like I feel like this would be a very good test question because this is for your life. So FAST, okay, these are the things you look for if you suspect a stroke. Is one side of their face drooping, or you can have them hold out their arms like straight like this, and if one side is lower and they can't raise it, that's a dead giveaway. Something's wrong. If they can't pick something up with one hand but not the other, like one of the neurological tests we'll do in the hospital is have the patient kind of push back on the nurse's hands when they'll pull and things like that. If one side is decidedly weaker than the other, I don't care if it's arm or leg, frankly, but the acronym is for the arm. Hospital yesterday. Okay, if they suddenly can't speak or understand, like I said, hospital. So especially if you've got all three of these, let's go. So that's what the T is for. It means call 911. It means time. Okay. And I say this as somebody who has had family members who had strokes. I'm being so for real with you right now. This is life-threatening. Okay. The longer that area of the brain is without blood and oxygen, the more pronounced the damage and the cell death, and possibly death. Okay. We don't want that. So for treatment, because remember this is a clot, so we need to break up the clot, okay? You're going to take medications that are anticoagulants, anti meaning against. Coagulation is blood clots. So it's going to break up that clot, okay? Aspirin is a very common blood thinner that is an anticoagulant. So a lot of older folks, if they have different heart conditions, they may take a daily aspirin. And that's fine if their doctor tells them to, okay? But it is a blood thinner. So then they have to worry about, well, if they're a fall risk because they're older and maybe they have hip replacement or mobility issues. Well, if you're on blood thinners like aspirin and you fall, you bleed out very quickly. It's not good. So there's give and take. Okay, and then so that is a stroke. Now the flip side is an aneurysm. So this is where your blood vessel gets weakened in an area and starts to kind of puff up and bulge a little bit. And it's, people can have aneurysms where they've got this specifically the weakened and bulging blood vessel for a long time and not even know it. The problem becomes when there's a hemorrhage involved, meaning the blood vessel ruptures, which means you are now bleeding internally. And you're probably going, well, blood's supposed to be inside me. That doesn't make sense. Yes, that's true. But blood should be within its contained little blood vessel, so it goes in all the right places. Okay, well, now if it's not in its nice little contained blood vessel, it can go wherever the heck it wants. This is a hemorrhage. This is a bleed. It's not good. So it's the exact opposite of a stroke. For a stroke, we have a clot. We need to break up the clot. For an aneurysm, it's a bleed. We need to stop the bleed. So you want it to clot. Okay, and again, if that hemorrhage is involved, it's life-threatening. This can also be noted by a sudden, severe, like diabolical level of headache. Okay. They can also have a stiff neck. They may suddenly start vomiting, have a seizure, things like that. Okay. Typically, to help these patients, they will put them on quickly on a medication to stop the bleed, and then they're going to do surgery once they figure out where it's at to put in a stent, which is like this thing they put around the blood vessel to help structure it, support it, basically. Kind of like how you put like scaffolding on the side of buildings when they're doing construction, kind of like that. So make sure you know that acronym, not only just for a test question, but life. Okay, it could literally save someone's life. Okay, epilepsy and seizures. Keep moving the little face around. Okay, seizures are a brief disruption of brain activity, kind of like almost like an electrical storm in a sense. So it's like a brief disruption of whatever's going on in the brain. This can cause changes in your awareness, your movement, your behavior, things like that. So seizures can be a symptom of something else going on. Like if you suddenly hit your head, that can cause a seizure. By the way, don't do that. Or they could be a chronic situation, in which case this is epilepsy. So epilepsy is where you're going to have chronic recurrent seizures, oftentimes for most of their life. Sometimes these epileptic conditions can start in childhood. Sometimes it's an adult, triggering trauma, head trauma event that starts it, and then now they got epilepsy. Kind of varies. There's different types of seizures in terms of like severity and like where in the brain they are and how widespread they are. It varies. They can be triggered by certain things like stress or sleep issues or hormonal changes or taking substances you're not supposed to. Dehydration, overexerting yourself. There's a lot of different triggers for people who have this condition. And again, there is unfortunately no cure, but they do make anti-seizure medication. So it helps kind of like put a stop to that just sudden burst of like electricity that can cause this. So they usually work really effectively, but they are, like most medications for chronic conditions, you have to be very consistent with them. Okay, meningitis. So again, this one is something that you need to know about as a high school student. So, haven't gone into too many details about it. Let me show you real quick. So around the brain, you have these layers called meninges. Okay, so here's your skull, here's your brain, and in between, we've got the dura mater, the arachnoid matter, and the pia mater. Those are 3 levels of meninges. So think of meninges as like, they're all different thicknesses and durabilities. Like the dura mater is the most durable, okay? And the arachnoid matter is named as such because it looks like spider webs. It's all the blood vessels. I think on the samples we'll be dissecting for the sheep brains, I think they have meninges on them. You'll see them. But essentially, these meninges function to add an extra layer of protection for the brain. And they're also around the spinal cord. The problem is meningitis can happen. So remember, itis means inflammation. So this is literally saying inflammation of the meninges. That inflammation can come from most of the time it's from an infection. There is viral, bacterial, and fungal meningitis. Obviously, treatment's going to vary on which kind you have. Bacterial is treatable. Yay! If you get to a doctor in a timely manner. Okay. Meningitis can be deadly. So if you have the symptoms, go to a doctor, please. Okay. But hopefully what will happen in this case for you is you will get the meningitis vaccine before it's ever a concern. And what's going to happen here is pretty much, I think it's still a standard requirement, and it should always continue to be. When you move out of your house after high school graduation, you're going to college, yay, you're going to move into a dorm. Pretty much all freshmen have to live on campus at almost every single university in the world. Okay, at least in America. I should say America. When you move into that dorm, before they let you move in, they're going to ask you to show proof that you have the meningitis vaccine. Because in shared living areas, whether it's the dorm or the military barracks or wherever you end up, diseases spread very quickly because you're in close confines and you're surrounded by people who you are not related to and have never seen before. You don't want to get meningitis your freshman year of college. So you are going to go get that meningitis vaccine. It's going to protect you from this. I'm not saying you're not also going to then get every other disease known to humankind in the dorm, because my roommate definitely did in college. And I was just like, they're there. Don't breathe on me. But this vaccine is going to help you prevent getting that. Okay. So if you have the symptoms and those symptoms are starting to get worse and it's like a sudden onset, go to a doctor. And by doctor, I mean emergency room. Go. Okay. Because again, this can lead to brain damage if left untreated, which can have lifelong complications. So symptoms you need to watch out for: a sudden, again, diabolical headache, fever. That one of the dead giveaways is a stiff neck. Okay. Confusion, sensitivity to light. If they suddenly have seizures and they don't have epilepsy, never had a seizure before in their life, oh my, go to the emergency room. Okay. They might have nausea, vomiting, things like that. Okay. Next up is migraines. So migraines are not just headaches. Please don't say that to someone with migraines. You may get slapped, because I promise you they're not. Okay, so a headache, don't get me wrong, headaches suck. No one wants them. But headaches usually go away after a period of time. Maybe you take a little bit of like some Tylenol or ibuprofen. Maybe you drink some water, take a nap. They go away. That's the point. Migraines are different. Migraines are persistent. They're recurrent. They tend to be pretty localized in one area of the brain, and they tend to always stay in that kind of same area. They can come with these things, with this aspect called aura, which is where the person may be sensitive to light or sound, or get nauseous and just throw up for 3 days straight while their head is about to explode. That's not a headache, y'all. Okay. This is a neurological disorder. It gets its own designation for a reason. They may see things in the corner of their eyes. They may lose parts of their vision. It's wild. Okay. And it varies, again, person to person to person. So they can have what are called migraine attacks, and that's where they have this migraine with all the aura and the other symptoms, anywhere from 4 hours to a few days. And then after that, because generally speaking, when a person is in a migraine attack, say it's a several-day attack, they don't really get much sleep. So afterwards, there's a recoup period of like a day or two where they are very fatigued, they're confused, they've got to re-nourish their body from throwing up for 3 days, rehydrate, the whole works. Like sometimes people get hospitalized because of migraines. Like that's how bad it can be. And if this happens so frequently that they can't go to work, they can't take care of their kids, they can't take care of their pet, they can't go grocery shopping, whatever it is, this is a disabling thing. Like people can get disability for migraines if they're that bad. So for treatments, they do have medications out there to mitigate the pain, although your body can build up tolerance and be resistant to that medication over time. They also have medications that can help prevent the migraines, but again, it could take some finagling to, is this medication going to work, or is that one? Or you've got to figure it out. Knowing the triggers is going to be person dependent, and so they can avoid certain triggers. So yeah, again, I know people with migraines. I had some migraines in college. I'm good. I don't want it. Okay. So you can kind of see on this little infographic, you can see the different comparisons. Okay, now let's talk about brain injuries. So we're going to talk about two specific kinds of brain injuries. The first being TBI, or traumatic brain injury. And then we'll talk about CTE. Okay, so traumatic brain injury, it's an injury to the brain that affects its ability to function. Pretty standard definition, right? A lot of times this injury is caused by a fall or maybe like a car accident or something like that. Okay. So it's weird when you think about it, but your brain is essentially floating in your skull right now. Okay. Yes, we have the skull for protection. It's got the meninges that help protect it too. It's got cerebral spinal fluid to kind of help, cushion things. But it's literally just kind of like floating there, right? So sudden stops and starts of movement, your brain, if it like, will literally bounce off your skull essentially. Okay. And that causes damage. We don't want that. So again, the severity of your symptoms are going to vary dramatically here, because it could be like a mild concussion to a severe injury that can cause, like cell and tissue death in a certain area, which can lead to lifelong complications. It varies depending on what caused it, how long was treatment delayed, etc. So symptoms like can be headache, dizziness, confusion, mood changes, behavior changes, like severe brain injuries. The person can go through severe mood swings, behavior changes, personality changes. Like they can be a totally different person based on what area was affected and things like that. And again, there's different types of rehab and therapy out there, again, depending on what happened where. Do they need to relearn how to cook? Do they need to relearn how to drive a car? Do they need to relearn how to speak? Different things. Okay, and then we have CTE. And if I didn't have the labels down this picture I found online, you would probably going, well, that looks like an Alzheimer's brain. You're not wrong. So CTE, the full name is chronic, meaning lifelong, long time, right? Traumatic encephalopathy. Okay. Basically, this is a condition that is neurodegenerative, so it gets worse over time. And it is pretty rare, but the people who get it, we're starting to find a lot of commonalities in them. A lot of football players and boxers, people who had severe military traumas and, may have gotten kind of, overseas. Basically, it all comes down to hits to the head. The more time your brain is jostled in your skull, the worse it is over time. For some reason, America, one of the pastimes of the American people is football, right? We have a whole day of the week dedicated to Sunday football. Well, what happens in this case is these symptoms don't just show up immediately. It's not just one hit to your head. It's repeated over time, and sometimes they're worse than others. Sound like football? This is part of why I don't like football as a sport. Yes, you wear a helmet, but because of how they're allowed to hit and tackle, your brain is still taking a knocking. Okay, it's not good. And what happens here is over time, over all those repeated hits to the head, we're starting to see cell and tissue death. And what happens is later on, so like say the football player who, somebody on the NFL, I don't know names. They were somebody who played like pee-wee football, and then did like middle school football, and then high school football, and college football, and then NFL, right? So football, all the way. So that's a lot of hits to the head. Well, as they get older, as they age, they start having personality changes. They start having memory problems. And everyone's like, oh, it's just dementia, that just happens. But they found this in a, because nobody wanted to believe the doctor who found this. When he's like, it's football. You're hitting your heads too many times. Nobody wanted to believe him. Well, now when you scan the brains and you look at them, yeah, there's a true pattern. They're finding in boxers, they're finding in football players, they're finding in military combat veterans. And these people have sudden dramatic changes in their personalities, and they have mood swings, and they're aggressive sometimes when they used to be like, wouldn't hurt a fly. They lose cognition abilities. They have motor issues. Like, it's not good. Again, you can't diagnose it 100% in life, but because of, again, America's pro football, so that means we've got a lot of potential CTE cases cooking right now. They're starting to do some research and looking for biomarkers, so where they could take a sample of your blood, like from your arm, and look for certain proteins, so to speak, or similar that would be in the blood from like residue or waste tissue from the brain that's experiencing this. That way they would be able to kind of intervene a little bit earlier. Again, there's no cure for this, but they can maybe do, if they know like the biomarkers or something, they maybe like do some rehab or some, kind of therapies to help you out, not be so severe. Okay. Again, you can see another example here. Okay. So here's an Alzheimer's patient, 86-year-old with probable. Note the word probable because we can't diagnose until death. And then here's a 14-year-old severe TBI from either an accident or a knock to the head in a football game. Look how similar they look. That's frightening. Frightening. And then here's a 14-year-old who didn't get hit upside the head by something. Does not look like the Alzheimer's brain. Okay. Okay. And then last, to kind of sum it all up, again, that was a very, very quick spiel of not even close to all the different neurological disorders that are out there. Other things that can influence your neurological health and, how you perceive the world and things like that. Your diet, what you eat. Remember, we talked about the brain is very energy hungry. What you eat affects so many things, as well as your activity level, what exercise you get, how old you are, your genetics. I know you can't control that, but it does affect things. Your hormones, so which ones are present, how much there are of them, so on and so forth. That's also going to tie directly into, are you male or female? Because certain hormones influence cognition better or worse than others. And if you're like female, for example, estrogen is more prevalent than testosterone, although females do have testosterone. Okay, we'll get it twisted. Other things that can impact it, your sleep, so how much you're getting and how good, like the quality of the sleep. Okay. Are you taking any medications or other supplements? Do not smoke or vape. Do not consume substances you were not supposed to consume until you are of a certain age, or at all in this case. Okay. Do not. Your environment you live in, where you work, those can influence your neurological and mental health. If you have other health conditions, so you can be comorbid with like diabetes, as well as MS or whatever, like all that kind of compiles. And then one thing that a lot of people don't realize, your socioeconomic status. So how much money do you have? Just think about that. That affects how often and when and who you can go to see for a doctor. That's going to impact where you live. It's going to impact your stress levels. It's going to impact so much. Okay. And then last but not least, okay, so I know some of the topics in this video and the prior video, they're hard to talk about. Like, you probably know somebody who has one of these conditions. Maybe you personally have one of these conditions. Okay, I get it. It's hard to talk about sometimes. You're not obligated to tell me your whole life story and what your whole medical history. I don't need to know that unless you just are dying to tell me. But either way, just know it's okay to feel uncomfortable about some of these topics. I know I kind of joke and try to make light of some of them because that's how I get through it. Okay? Because again, I know people with a lot of these conditions. I'm not trying to joke and say they're they're not serious. But I want you to know it's okay to be approachable and think about these things like this. Okay? So if you do feel uncomfortable, if you are not like, I don't know about this, I'm worried, you can talk to a trusted adult. You can talk to me, you can talk to your counselor, you can talk to a parent, an auntie, an uncle, a pastor, I don't care. Okay? Either way, whatever you choose to do, remember you are loved and you have value. Okay? You're my kids. And I do want you to keep an eye on yourself and your friends. Okay, I don't get to talk to you guys about, have full conversations every single one of you every single day because there's a lot of you and one of me, sadly. But keep an eye on your friends. And if you notice something about your friend, like if their behavior's off, if something's going on, please tell somebody before something happens. Okay, that's all I want for you to do. And then here are some numbers in websites if you need them. Again, I'm not going to ask if did you call that number? I don't know. Call it if you need it, honey. Okay. So I love you. Have a good night. I'm going to stop recording now. Hopefully you learned something.